Okay, I think we're back online. So welcome to those who are joining us virtually. And I just want to introduce our next speaker, Dr. Oliver, who has come to us from Edmonton and will be speaking on PNH and aplastic anemia. Thank you.
Perfect. All right, that's working. Everyone can hear me? Now I feel like a pop star with my new microphone. I'm loving it. So my name is Monika, or Dr. Oliver, and I work in Edmonton at the University of Alberta. I do general hematology, but I have a focus and an emphasis on PNH and aplastic anemia. So a big thank you to everybody for allowing me to speak today and for the invitation. Disclosures, I'll be chatting about a few drugs, and I do receive some advisory board support, as well as am involved in a number of clinical trials for PNH. So the goal today, because this is the first inpatient meeting in 4 years, I'm actually going to start with an overview of the conditions that we're talking about, a diagnostic approach to both PNH and aplastic anemia. And then I'll discuss the current standard of care of PNH in Canada. And then I'll move into some of the recent clinical trials for new inhibitors, and finally finish with some of my closing thoughts on where I think the landscape of treatment is going. So we'll start with aplastic anemia. So aplastic anemia is a hematopoietic stem cell disorder, and it's basically associated with decreased hematopoiesis. And that's just the fancy way for saying a decreased ability to make blood cells. It's actually a misnomer. It actually should be called aplastic pancytopenia, because patients don't just present with anemia. They actually have all of their blood counts being low. And how we classify this disease and how we make prognostication decisions are really related to the depth of those cytopenias in the peripheral blood. And the severity also drives our therapeutic decisions. In Western countries, the incidence is somewhere about 2 per million per year, and about half of cases occur within the first 3 decades of life. That being said, it is pretty bimodal, so there's another peak in adulthood. Sometimes patients come to me with some confusion about what is bone marrow failure versus aplastic anemia, MDS, et cetera. So just a reminder from the terminology that bone marrow failure is really a broad term. It's an umbrella term, and that captures aplastic anemia, MDS, which we already spoke about, and PNH as well, if there is a bone marrow component. Pathophysiology-wise, we know, as I said, it's a loss of hematopoietic stem cells, and this can occur by a couple of different mechanisms. They can be autoimmune-driven. Sometimes there's a direct injury to the hematopoietic stem cells. This could be chemotherapy-related, drug-related, toxin-related, radiation exposure. Certain infections tend to do this, pregnancy, and then idiopathic in about 40 to 70%, and that's just our fancy way of saying we don't know. So how do these patients present? Patients present with pancytopenia, and that's low blood counts with inappropriately low reticulocyte count response. Our retics are our body's way of producing baby red blood cells that then should be maturing. And so we should be having a nice response if a patient's anemic, but we don't with aplastic anemia because the disease is at the level of the stem cells. Patients come to us with anemia. Their symptoms are usually fatigue, shortness of breath, pallor, which is being pale, syncope and headache. Thrombocytopenia, that's bleeding, bruising, and then neutropenia. So patients can actually first present with a severe infection, fever, or mucositis, which is mouth sores. The classification system, depending on where you read, this changes a little bit, but really the bulk of it is that we separate this disease into moderate, severe, and very severe. Moderate disease tends to be patients when we do their bone marrow who have less than 25% cellularity, but usually their counts are fairly reasonable. When we move into severe aplastic anemia, we're looking for 2 of 3 of the following. So a neutrophil count that's less than 0.5, platelets less than 20, and then that inappropriately low reticulocyte count response, so retics less than 60 or less than 1%. And then very severe are basically the same criteria as severe, but the neutrophil count is lower, generally at 0.2. Everyone probably in this room, if they know or if they've been diagnosed with a bone marrow failure or know someone, knows this lovely procedure, the bone marrow biopsy. And we like always getting this when we get it on medical school exams because it's easy to recognize. The bone marrow on the left, there's a normal bone marrow. So you can see it's nice and pink, filled up with nice cells, hematopoietic components, and then an empty bone marrow on the right-hand side. So that's aplastic anemia. Aplastic anemia is managed supportively. So we start by transfusion support to keep platelets greater than 10 or greater than, or hemoglobin greater than 70 or 80 plus, depending on the outpatient setting and what patients are able to tolerate in terms of their anemia. We try our best to limit transfusions in transplant eligible patients. And that's because we want to make sure that they don't become too alloimmunized. And we also want to prevent complications of transfusion. Often when we're diagnosing patients with bone marrow failure, the first thing that family and friends jump up to do is donate blood. And we encourage that, of course, but we encourage those donations to go to donors and not necessarily the index patient, just in case down the road, if some of those patients if some of those family members end up being a donor, we want to make sure that they are not at higher risk for rejection secondary to an immune response to the donor. Patients may require iron chelation from iron transfusions. And so this is, again, a side effect of repetitive blood transfusions. So usually on the order of 6 to 10 transfusions, the iron level becomes high in the body, and patients may require some chelation to try to get rid of that iron. Prophylaxis is something that's done to try to prevent infection. This could be fungal infections, bacterial infections, or viral infections. We spoke a bit about EPO earlier, as well as GCSF, which basically helps us to stimulate white blood cell production. And generally, this is not effective in patients with aplastic anemia because the disease is really at the level of the stem cells. Prognosis-wise, so although this is considered a benign condition, the prognosis is really not in line with most benign diseases. It's actually more in line with some types of leukemia that we see, which is that most patients eventually will succumb to complications of aplastic anemia, specifically infections or bleeding complications. And untreated severe and very severe aplastic anemia has a 1-year mortality of up to 70%. So really, we must make this diagnosis, we must make it promptly, and we have to initiate supportive measures and definitive therapy. Our definitive therapy comes with either immunosuppression or transplant, and I'll be talking about that. In patients with moderate aplastic anemia, when their counts are not so bad, sometimes it's reasonable just to watch these patients over time. And so what we'll do is basically just closely follow the blood work, maybe support them with transfusions. And what we're hoping is for basically if there was an insult, like an infection or drug or something like that, that we think caused the aplastic anemia, sometimes that will recover when that exposure is removed. And a small subset of patients actually go on to have spontaneous remission. We don't really know why. So this is really the treatment options for severe aplastic anemia. Generally, our first risk stratification is age. And so generally patients who are younger, especially pediatric patients and adult patients less than 40, the first thing in our mind is usually considering a bone marrow or stem cell transplant. That's done mainly if a matched sibling donor is available, and that only happens about 25% of the time. If you're over the age of 40, or if you do not have a matched sibling donor, those patients we think about immunosuppression. And ideally, we want or consider triple therapy immunosuppression, which I'll chat about. If patients don't have that or they fail to respond, then there are some kind of second line options that we use. So immunosuppression, it looks like this. Generally, there's 3 drugs that we're considering or thinking of. Horse ATG is an IV medication. It's given in the hospital setting, usually for 4 days, but usually that hospital admission usually requires about a week or so, depending on patient's response. And then 2 oral medications, cyclosporin, which is a drug that we start usually at the outset and then continue for a minimum of 6 to 12 months with a slow wean thereafter. And then something that patients may or may not know about, which is eltrombopag. The tough thing, which we were just discussing, is that the funding varies from province to province. And that makes it really challenging for us to know exactly what's going to be available, especially as I was talking about, I've practiced in a few different places, and that actually affects what treatments I've been able to offer for patients. So the standard of care when we are considering immunosuppression is horse ATG and cyclosporin. So we start there. But actually the preferred regimen, if funding allows, is adding in that third agent called eltrombopag. In patients with that third agent, about 52% of them will have a complete response at 12 months, with an overall response rate of 68% at 6 months, and the 2-year overall survival increases to 90% with treatment. Transfusion independence and improvements of the neutropenia does take some time, so generally on the order of 1 to 2 months. And we know that compared with horse ATG plus cyclosporin alone, that triple therapy allows us to have a bit of a superior response, and the toxicity is actually fairly equivalent. So adding L-ThromboPEG, so what is L-ThromboPEG? Well, it's a first-generation TPO receptor agonist. It binds the transmembrane domain of the receptor itself, and it acts in synergy, basically to stimulate hematopoiesis. So this is not just the platelets, but actually all of the cells. It was first trialed in patients who had refractory severe aplastic anemia, and about 40% of them had a response rate. It is an oral medication and the dose is high, so it's 150 milligrams once a day. I say high, that's in comparison to some of the other diseases that this is used to treat, some of the other diseases that L-ThromboPEG is a treatment for, such as ITP or immune thrombocytopenia. We do generally dose reduce Asian patients because their metabolism is slightly different. The drug's fairly well tolerated. Most patients don't experience significant side effects, but those who do tend to have some skin rashes, nausea, cough, diarrhea. Some patients have headache, fatigue, and then we do monitor their liver enzymes because that can be a toxicity. This on the right-hand side is basically a published New England Journal paper from 2022, and they showed basically the long-term outcomes of patients who are on triple therapy. What you can see there in the blue is that patients had a hematologic response of 22% with triple therapy in the blue, compared to only about 10% in the yellow. And then the secondary endpoints that they looked at were the median time to first response, which is significantly lower. So that's what we want, a more brisk, quick response. And then the complete and partial remission rates or complete and partial response rates at 6 months were also higher in the group that got triple therapy. We talked a lot about different cytogenetic changes and mutations that we can see in MDS. And with aplastic anemia, there's a concern that because we're constantly bugging the bone marrow to produce more when patients are on Revolade, that we can stimulate some clonal evolution. And so that's something that when patients are on L-ThromboPEG, I generally do serial bone marrows in them so I can make sure that if there is a clone there, it's not increasing over time. Treatment of the less fit or frail aplastic anemia patients. So these are patients who tend to be older or maybe have other medical comorbidities that make it more challenging for them to be given treatment with FRCPC. That's the one that really is probably the most immunosuppressive. And so really we're guided in this kind of domain by patients' values and philosophies of care. So it's really a discussion with the patient and family regarding treatment. Generally, we are offering lower intensity therapies for them or supportive care. And sometimes we'll start with just L-ThromboPEG or cyclosporin if we have funding with L-ThromboPEG in that setting. We can also use other adjuncts like anabolic steroids such as danazol, and then the anti-CD52 monoclonal antibody called alemtuzumab can also be used in this group, more in the refractory population. So transplant. So as I mentioned, stem cell transplant actually is a curative option for aplastic anemia, but transplant is not to enter into lightly. So there is the potential for significant morbidity and mortality, and so we have to choose our patient population quite wisely. Stem cell transplant is great in aplastic anemia because it basically performs two actions. One, it helps to replace our hematopoietic components, but it also helps to replace the immune system that is causing the destruction in the first place. The outcomes and how patients do in transplant are really dictated by the recipient's age, which is why we're tending to do younger patients, the donor availability, so who does and does not have a sibling match, the match of the donor, so how closely they're HLA matched, and then what conditioning regimens, which is the chemotherapy we use to clean out the bone marrow prior to proceeding with transplant. Generally, as I mentioned, this is first-line therapy for children and adults under the age of 40. So that's kind of an overview of aplastic anemia. So it's a benign but life-threatening bone marrow condition. We need treatment, and the type of treatment is determined by the severity of the cytopenias. Upfront immunosuppression with triple therapy, horse ATG, cyclosporin, and L-ThromboPEG. It's shown as of more recent studies to result in superior CR rates and more brisk time to response than dual therapy. It's not funded in my province in the upfront setting, and that's because it doesn't necessarily have a survival advantage. And so it does help with getting patients into a nice response, but patients who are receiving dual therapy are not necessarily going to have poor outcomes with regards to survival. The only cure remains hematopoietic stem cell transplant, but I do think there's lots of space in this domain and in the treatment landscape for new therapies. And we would love to have more data on certain patient populations like moderate AAA, patients with AAE who become pregnant, elderly, or medically frail patients. And so with that, I'll move on to my next love, which is PNH. So PNH is an acquired ultra rare benign clonal abnormality of hematopoietic stem cells. The prevalence here is estimated somewhere between 0.5 to 2 per million per year. And it was first named because there was a belief that this hemolysis or blood cell breakdown was occurring through the mainly in the night and in paroxysm, so in spurts. Now we know that there's probably chronic hemolysis going on, and it's happening both during the daytime and nighttime. It can affect any age group, but again, most commonly presents by that third decade of life. And there's no particular patterns that we recognize with regards to geography, race, ethnicity, or sex. It is chronic, it is life-threatening, and it has a 5-year mortality of about 35%. So what is PNH, or what's going on in patients with PNH? So the defect is in a particular gene called the PIGA gene, and that's located on the X chromosome. And this leads basically to the absence of GPI-linked anchors, or the other way I say this is they're missing their babysitters or their chaperones. So normally these red blood cells are studded with these nice GPI anchors, and that helps protect them from our complement system, which otherwise would destroy them. But in PNH, we're basically missing those anchors. So what happens is we have this uncontrolled, unregulated feeding frenzy of the immune system of the complement cascade, and it can arrive completely spontaneously, or what we call de novo, or it can be associated with bone marrow conditions, bone marrow failure conditions like MDS, aplastic anemia, or other myeloid neoplasms. So this is kind of a schematic of that. We basically have that PIGA mutation that starts in a single hematopoietic stem cell. That over time expands, and so that one cell becomes many cells, and those many cells eventually affect their different cell lineages when they grow up. So they eventually grow up and become differentiated, and that's where we see those PNH clones. This is the dreaded complement cascade. This is a nice simplified version, but as somebody who's done a fellowship in complement disorders, I'll tell you it's much, much more complex than that. But basically there's 3 points of entry into the cascade: classical, lectin, and the alternative pathway. And they converge in 2 time points. One is the proximal part of the cascade, that is C3 convertase. So that's kind of the anchor for the proximal part. And then we have C5. C5 is the kind of anchor for the distal part of the pathway. C5 basically results, when that's activated, it results in the terminal complement system, and that's basically activation of protein C5b through 9, and then that results in something called the MAC attack. The MAC stands for membrane attack complex, and it's basically a hole puncher that goes around and should be punching holes into bacteria, but instead in PNH, it's actually punching holes into the red blood cells, leading to hemolysis. So these are those nice studs that I was talking about. They're like accessories for the red blood cells, and they normally help to chaperone them so they're not being destroyed. But in patients with PNH, they have that bare, lonely, no GPI-linked anchored red blood cell that bursts or results in hemolysis, and we're left with this free hemoglobin. So the classic triad that we learn about is DAT-negative hemolysis, thrombosis, and bone marrow failure, but patients aren't going to walk into our office and say, I have bone marrow failure, thrombosis, and DAT-negative hemolysis. They're going to say their clinical features, which of course are fatigue, dark urine. Dark urine happens as those blood cells break down and the free hemoglobin is released into the urine. Jaundice, yellowing of the skin, chest pain, shortness of breath, abdominal pain. So sometimes that's the presenting feature. It's very crampy. Kidney dysfunction, as basically the remnants of those red blood cells are trying to be filtered through the kidneys. And then smooth muscle dysfunction. In gentlemen, this may present with erectile dysfunction. And in all patients, it could present with difficulty swallowing, pain or esophageal spasms, or pulmonary hypertension over time. But the most disastrous and life-threatening complication of PNH is thrombosis. So a bit on thrombosis in PNH. It looks something like this. We're not going to talk about that because it's Saturday morning, and I'm not smart enough to do that. So we'll talk about this, which is basically the simplified way that I think about thrombosis in PNH. It's a number of different factors that are going on. One of them is that normally our body makes nitric oxide, which is a potent dilator. In PNH, we have the opposite problem. We know that platelets, or those sticky cells, become activated, making PNH much more thrombotic. We have a huge inflammatory cascade within the complement cascade. So there's all of these potent anaphytoxins that are released in cytokines. We have endothelial injury as we have more and more hemolysis happening. And then lastly, when the clots are formed, we have difficulty breaking them down. So that's called fibrinolytic system dysfunction. PNH will occur, thrombosis will result in a terminal event for patients in about 30 to 45% of patients with PNH. Most of the time, typical places are involved. So typical places would be blood clots in the legs or the lungs, which are deep vein thrombosis and pulmonary embolism respectively. But PNH is known for presenting in weird places with clot. So they can have hepatic clots or something called Budd-Chiari syndrome, or they could actually present with CNS clots in the brain. So things like cerebral vein thrombosis. And sometimes when we have a young patient with a clot in a weird place, that's kind of the impetus that makes us think, something could be going on. This could be PNH, and that sometimes prompts patients physicians to do testing. It, as I mentioned, is the leading cause of mortality, occurring in about 40 to 70% of patients who are untreated or undertreated. And we'll talk about that. The first recognized thrombotic event can be fatal, and we know that when patients have thrombosis, their risk of death is going to go up, and so we really have to treat those patients. Their relative risk of having a clot is 62 times that of the general population, and that's very high compared to some of our other thrombotic disorders. There was a study done in 2012 by Dr. Scully, who actually went and looked at patients who have PNH who were totally asymptomatic, and she went and scanned their lungs and found many of those patients actually have subclinical thrombosis, which means that they have tiny blood clots in their lungs, but they actually don't have symptoms. So those are kind of subclinical. So it tells us how thrombotic this disease is. And most of the time, these clots are presenting in our venous system, about 85% of the time, but it can affect arteries as well. So things like stroke, heart attack, or arterial vein clots. This is what we do for diagnosis. So we start with a CBC and differential, that's our first clue. And then we do our hemolytic markers. So those are things like bilirubin, which is elevated, LDH, reticulocyte counts, which I chatted about, haptoglobin, which binds for hemoglobin, so it tends to be low, creatinine, which may or may not be elevated, a blood smear, which actually will show some of the fragmentation, and then a DAT, which helps us to determine the type of hemolysis that's happening. We look in the urine as well to see the long-term breakdown products of hemoglobin. The bone marrow, which I already mentioned, but really what we use to clinch the diagnosis is something called the flow cytometry. This is what flow cytometry looks like. So it's basically a laser-based technique where we fire cells through a machine to detect their expression, the receptors that are on the outside. And that allows us to basically characterize the population of cells that we're seeing and put them kind of in different boxes to determine what disease they have. In PNH, it's actually the absence of specific receptors we're looking for. So it's the absence of those GPI-linked anchors, that CD55 and CD59, that ultimately help us characterize the population. And the plots look something like that. So it looks pretty psychedelic. Those are the plots that are then read by our hematopathologists. I showed you that PNH can form different populations in different cell lines. The most stable, the one that we want to look at, is the white blood cells. And that's for a few reasons. The white blood cells are more stable because they're not being affected by transfusions. So in patients who are getting transfusions, that can affect their flow cytometry results. And then second is the white blood cells are not affected by hemolysis. So they're not being burst and broken down like the red blood cells are. The red blood cells, we characterize them based on 3 different types of cells. Type 1 are cells that have normal GPI expression, so they essentially do not have PNH. Type 2 have partial GPI anchors, so they have partial expression. And then type 3, they basically have no GPI expression. But you can imagine the more kind of the higher clone you have of your PNH red cells, the more hemolysis is going on. And so again, that's not the most accurate, the red blood cell clone. So we use the white blood cell clone. We classify, similar to aplastic anemia, we classify PNH. We have patients who present with classic PNH. These are the patients who usually come in with florid hemolysis. They can come in with thrombosis, that dark red urine, and the bone marrow findings. Generally, the bone marrow is pretty bland. We're not seeing too much, and they usually do not have karyotypic abnormalities, and their clone size tends to be really high, greater than 50%. We may see PNH that's in the setting of bone marrow failure. So these are patients that present kind of a variable hemolysis. Usually when we're doing the bone marrow, we're seeing MDS or aplastic anemia as the dominant morphology. They may, and most likely, will have cytogenetic abnormalities. And the clone size is variable, probably somewhere in the order of kind of 1 to 50%. And then subclinical, these are patients who, for whatever reason, get a PNH flow cytometry. Maybe their clone is somewhere on the order of less than 1% or 1 to 10%. Most of the time, they do not have hemolysis. Their bone marrow looks fine, or they may have maybe some really early changes of bone marrow failure, and they're on their way to basically turning into a bone marrow failure with PNH clone. This just shows a bit of a breakdown of PNH clone size based on different diseases. So PNH, classical PNH, again, tends to present with a really large clone, greater than 50%. Aplastic anemia, somewhere in between, 10 to 50%. And then MDS, they tend to have smaller clones, somewhere on the order of 1 to 10%. What we do know, higher clone size, more hemolysis, more LD. And so when we're putting it all together, and I'm speaking to family doctors and other hematologists who might not recognize or might not treat PNH, we use this catch criteria. This helps us just to kind of stimulate our brain to remember when we should be sending PNH flow cytometry. So cytopenias, which are unexplained, hemolytic anemia, thrombosis, which is unexplained, hemoglobinuria, and then presence of other bone marrow failures. And that just sort of trigger our brains that we should be ordering PNH flow cytometry. Early diagnosis of PNH is absolutely paramount because we want to try to prevent these long-term complications. And often when I'm meeting and discussing with PNH patients, they've had a whole rigmarole of tests and emergency visits and everything else before somebody actually picks up on the diagnosis. And so I really like to propagate, some easy way to remember this. So talking about treatment, so similar to aplastic anemia and MDS, all of our patients receive supportive care. That comes in the flavors of doing transfusion support, hematinic support, so just making sure that we're optimizing their vitamins so that they have the building blocks to make red blood cells. We also know that the folate is being depleted because the blood cells are being broken down, and the iron is also probably being excreted in the urine, so they need iron replacement. They may need analgesia or pain control to help with that abdominal pain or some of the esophageal pain that they're having. Thrombosis has to be treated. Patients must be started on blood thinners, anticoagulation. But I generally, and it's kind of the practice here and in Ontario and in most places in the world, to start patients on primary prophylaxis if there's a funding issue or we're waiting for their drug to be started. So we start them on a low dose of a blood thinner while we're basically waiting until we can get more definitive therapy for them. Stem cell transplant, similar to aplastic anemia, is the only cure that we have for PNH, but it's almost never done. And the reason why is that high morbidity and mortality that I mentioned, and we have such good treatments. And so generally we offer patients treatments, and it's only in patients who have had, horrible bone marrow failure syndromes like MDS or aplastic anemia that have another indication for transplant, then we then transplant PNH patients. But really the mainstay of treatment is complement inhibition. So most people will be well familiar with this drug, eculizumab or Soliris, which is the other name. It's a monoclonal antibody that basically puts a clamp on the complement cascade in the distal part of the cascade at C5. And that's going to prevent that terminal MAC attack that I was talking about, which leads to hemolysis. In 2007, it was FDA approved for PNH based on its efficacy in 2 phase 3 trials, which were Shepherd and Triumph, and I'll show you the data on those. And in 2010, it was priced as the most expensive drug in the world. So you can imagine these patients, especially if they're being diagnosed by the age of 30 or 40, this is something that they're being maintained on for the rest of their lives. So they quickly become million-dollar patients. My mom always joked, of course, I chose PNH as my specialty because I like expensive, high-maintenance things. And so they're like, it's a perfect fit for you. So eculizumab, the dosing schedule, it's a drug that's given, as I mentioned, IV every 2 weeks indefinitely. It starts with a loading period or induction phase where it's given weekly for 4 doses. And then at week 5, the doses switch from 600 milligrams to 900 milligrams. There are black box warnings. The biggest one is meningitis. So our complement system is part of our immune system. It's meant to protect us against bacterial infections. So we're putting a clamp on that. That risk of infection goes sky high. So all patients must be vaccinated against meningococcal infections. This is with Men-B, so meningitis B, and ACWY. So those are different serotypes. And we vaccinate them at the outset and then basically every 3 to 5 years thereafter. I also put my patients on primary prophylaxis. So as long as they're on an inhibitor, I usually recommend that they're on a low dose of penicillin to protect them from any bacterial infections. And I also consider other vaccinations for other encapsulated organisms. Outside of the meningitis risk, it's a well-tolerated drug. It tends to have headache in about half of patients. That tends to be mild, and it usually is more the first couple of infusions while we're depleting some of that nitric oxide. And then nasopharyngitis and upper respiratory tract infections, some nausea, some back pain. These are the results of the phase 3 trials. That's LD, so our marker of rapid cell turnover, and you can see just absolutely drops after starting treatment. So there was an 88% reduction in LD 1 month after starting treatment, and about an 87% decrease in hemolysis, which was maintained for the 36 months, which was the length of the trials. Most importantly, it improved survival. So on the left, you see the two different curves. So patients with PNH obviously had inferior survival outcomes, and then patients were started on Soliris, and you see those curves come together. So that was so amazing. This is really game-changing for PNH and a number of other complement conditions. So what are the therapy expectations? I always like to sit and go over this with patients when they're starting on therapy. In the first week, I get to see the change. So that's the LD starts to come down. It's so satisfying to watch the blood work in my little OCD brain. It makes me feel so good. But then really between weeks 2 and 3, that's really when we start to see patients start to improve their quality of life. By weeks 2 and 6, we see reductions in transfusions and their hemoglobin levels start to stabilize. I think I said 2 to 6 weeks, I meant months. And then greater than 6 months, we see ongoing improvement of quality of life. Their hemoglobin concentration starts to stabilize. And then at 36 months, we see basically the hemolysis, the hemoglobin nice and sustained. And then at 8 years follow-up, there was that survival advantage. So after all of that overview, I'll talk about a few novel therapies that are coming down the pipes. But the big question is, well, you just showed us that Soliris is pretty awesome. So why do we need any new therapies? Well, there are some complications. The first one is I think it's almost a misnomer to call these drugs inhibitors or blockers because they do the best they can, but they can't block everything. So it's more like a clamp where sometimes some of that intravascular hemolysis is escaping. And so there are patients, about up to a third of patients who don't normalize their hemoglobin completely and continue to have some hemolysis. There is a small subset of Japanese patients that have a polymorphism in C5. That's exactly where Soliris wants to bind. And so Soliris can't bind, and those patients are complete non-responders. We don't have any in Alberta. I don't think there's any in Ontario either, but definitely, something that could happen where Soliris is just not the right option for them. But the biggest issue that we have with Soliris with regards to response is something called C3-mediated extravascular hemolysis. What's happening here is we clamp the cascade at the end, but we still have the proximal part of the pathway, which is, firing. And that C3 becomes deposited and tagged on all of the red blood cells. And then the body's smart, and it basically still hemolyzes those blood cells, but instead of going intravascularly, it goes through the spleen. And so this is a problem. The infection risk, which I told you about, is also an issue. The biggest thing, though, is the convenience. So when I sit down and tell, a 35-year-old, you're in an IV treatment indefinitely for the rest of their lives, that's a pretty shocking thing for most people to experience. So that's definitely something that can be benefited or improved upon. And then the route of administration. So it's an IV drug. I don't really like getting IVs, especially every 2 weeks. And some patients just don't have the veins for it. So sometimes we need to put in special lines or even ports. The other thing is it makes it really challenging to travel. Lots of places around the world do have access to Soliris, so patients are able to travel and we can arrange drug for them wherever they go. But sometimes they'll go to more rural places or, for example, places in third world countries, and we just don't have access to Soliris. They don't have infusion clinics, and so they really can't travel to those those places. The other thing is that these drugs are so expensive. And so the more competition we have in this space, the more the drug costs will start to be driven down. And we also know that the more clinical trials we do, the more we're going to learn about the complement cascade and the more opportunities we have to maybe target different parts of the cascade, which hopefully one day may lead to a cure for PNH. The other big thing to note is that Soliris or eculizumab, it does not treat bone marrow failure. So if you have small MDS or aplastic anemia in the background, it's not going to treat that. And it actually doesn't treat the gene mutation itself. So these are now the FDA-approved complement inhibitors. Like we heard about this morning, the states are usually quite ahead of us. So you can see the different drugs here, their mechanisms of action and how they work, and the dates of approval in the states. I can tell you eculizumab is approved. It's first line. Ravulizumab has been approved, but we're still not able to get it and prescribe it publicly. So that's coming hopefully in the next couple of weeks to months, I would estimate. I'm hoping. Egcetacoplan is also a drug I'll be chatting about. So this I just like to put up because this is what I look at when I need a bit of inspiration when I'm treating PNH. These are all of these little dots are different clinical trials that are happening. This is even outdated. This is from 2019, but preclinical phase 1, phase 2, and moving into phase 3 and drugs that are improved, there's a lot coming down the pipes for PNH. So this is often what I'm seeing when I'm looking through my email inbox, just really exciting to see a bunch of different new drugs that are being published. So I'll chat quickly about ravulizumab because this is probably the one that I have patients on from clinical trial, as well as a few patients who are on the drug who have been able to fund it in different ways. Ravulizumab is a C5 inhibitor. It binds the same epitope as eculizumab, but the benefit is that it's given every 2 months instead of every 2 weeks, so it has a longer half-life, and that helps to reduce the annual cost. I'll show you some of the data from the different trials, but basically patients who had previous exposure to Soliris, who were eventually switched over to Ultomiris or ravulizumab, 93% of them actually preferred the drug. 88% of them thought that they had better overall quality of life. 98% of them thought that they were better able to plan their activities, and 64% of them noticed a change in their fatigue levels. So these are the 2 trials. These were the phase 3 trials, study 301 and 302, Alexion 1210. These studies were basically done to show how patients would react both in the naive setting and in patients who are already stable. So the 301 study were patients who were complement naive, which means they had never been exposed to a complement inhibitor. And then study 302 were patients who were already on eculizumab. These were the primary endpoints for the naive patients. So they tended to have better transfusion avoidance. Their LD levels tended to normalize and then, move more towards normalization. And then the secondary endpoints as well, their change in facet fatigue, breakthrough hemolysis, et cetera, tended to favor ravulizumab. And then the same thing for the trial in patients who are already stable on eculizumab. So the other one that you may have heard is egcetacoplan, or APL2 was the study drug name. Egcetacoplan, or Empaveli, is the first approved C3 inhibitor. So now instead of targeting at the distal part, we're targeting proximal. This is actually approved already in the US as well as the EU. In the EU, it's for patients who've basically been on a C5, so Soliris or Ultomiris, as I mentioned, but they're still having persistent anemia despite 3 months of treatment. The benefit of the proximal ones is they basically target that proximal part of the pathway. And so we think that there's not as much extravascular hemolysis happening because basically the C3 is being blocked. So we're not able to tag those red blood cells for destruction. It is administered as a subcutaneous agent, so twice weekly. I put that with an asterisk in the benefits because some patients do like that IV preparation every 2 months. And so it's really up to patients. But I know some patients of mine on this drug say they love having the opportunity to bring the drug with them when they travel. They're in control and they don't have to go back and forth to hospital, especially during the pandemic. That was a big deal. This, just like the other complement inhibitors, has the risk of meningitis. Patients must be vaccinated, but tends to be well tolerated, with diarrhea and injection sites being the most common reaction. This is a slide that was prepared by Sobi. This is just showing basically the different clinical trials. So starting out at phase 1 and then moving into our phase 3 trials, which were Pegasus, Prince, and then our extension study. So this is the Pegasus trial. This was basically patients who were started on egcetacoplan. There was a run-in period with eculizumab, and then patients were eventually switched to either egcetacoplan or eculizumab. And then after the open label extension, all patients got the drug. The trial outcomes here. This is also the plots where egcetacoplan for the first 2 is on the right-hand side. So in general, there was more of an improvement from in their hemoglobin level and their transfusion dependence. And then the facet fatigue score as well was non-inferiority was not tested. So I thought I'd bring this up. This was presented just in December by Dr. Patrickman, who was my mentor and also works here in Toronto. So this was basically the results of the long-term safety and efficacy data of egcetacoplan. So this looked at the 307 study, which was our basically follow-up study which looked at the phase 1, phase 2, and then phase 3 clinical trials. And basically the long-term results is that egcetacoplan had robust and sustained improvements in LD and fatigue in patients with PNH. About 80+% of them were able to actually be liberated from transfusion. So that's remarkable. And then the long-term safety data was comparable to what we saw in the clinical trials. breakthrough hemolysis, so now where the pegcetacoplan just isn't doing the job, it's an issue with a small subset of patients, but that they're actually doing a study right now looking at either giving the drug more frequently, so every 2 to 3 days, or giving an IV dose of pegcetacoplan, or giving a dose of eculizumab if patients are running into issues with hemolysis. And this was Health Canada approved, and there was a patient support program that launched in March. So some patients, if they had private coverage, we can explore this as an option now. And then the last one I thought I'd bring up, so there's factor D inhibitors and factor B inhibitors. There's so many exciting things to talk about, but I had to talk about something oral. So this was also presented at our annual hematology conference in December. Iptacopan is a factor B inhibitor. So this is an oral drug that actually acts, again, in the proximal part of the pathway. And the data that they represented or presented, I should say, at ASH was the primary efficacy data from a 24-week randomization trial, which was multi-center phase 3, and it was called the Apply PNH study. This is what the study design looked like. So most patients, or all patients, were on a C5 inhibitor, and then they were basically randomized to iptacopan or to staying on their C5 inhibitor. And they looked at increase in hemoglobin greater than 20 points, and patients who were actually able to get to a hemoglobin greater than 20, which in female patients is essentially normal. So the primary endpoints, very impressive data. This drug was able to increase their hemoglobin from their baseline by up to 20 points or more, and that was seen in 82% of patients who were on the iptacopan group versus only 2% in the patients who stayed on their standard of care. Hemoglobin getting greater than 120, that was seen in almost 70% of patients compared to less than 2%. And then lastly, it was superior to standard of care to improving the hemoglobin and improving FACIT-Fatigue scores. And that's basically what we're using to assess patients' quality of life. So last slide, wrapping it all up. So complement inhibitors, both proximal and distal, continue to be costly. And even though I'm talking about these drugs, I'm so excited, and I hope they're going to manifest by my career. As we talked about, there's lots of delays to actually getting public funding for these drugs. We expect that there's going to be new modalities. So instead of this being a drug or a disease that we can only treat with IV, as we currently do now for most patients, we're going to have subcutaneous options and oral options. And it's going to be so interesting to hopefully sit down one day with my patients with a menu option of different treatments that they can choose. Serious and fatal meningococcal infections are going to be present no matter which complement inhibitors we choose. And so we have to make sure patients are vaccinated and considering primary prophylaxis. We still have some unanswered questions for patients who are pregnant, patients who have concurrent bone marrow failure disorders. And so we need some more data on those particular groups. And then there always is a question that comes up: is there going to be a role for blocking the complement cascade in multiple places? Right now, that's cost prohibitive. We couldn't do that. We also have to question how far do we go when we're blocking the complement cascade? Could that result in other issues that we don't know about? Overall, a point of optimism to leave you with on Saturday, that it's a really exciting time for PNH, and I feel really fortunate to be involved in this space. So with that, I will conclude. If there's any questions, thank you so much.
So I have a low clone. Can it stay a low clone forever?
It can, absolutely. So generally what we do is I do PNH screening for patients at least annually, depending on their clone size. Sometimes we'll do it every 6 months. And we basically watch it over time. So if it starts to kind of creep up, and especially when it gets kind of greater than the 10% mark, I'm doing it a bit more frequently, then usually greater than 50%, that's your dominant presentation. You're really, at that point need to be treated like a PNH patient. But some patients have a very small, like less than 1% clone, just always in the background. And that in patients with aplastic anemia actually predicts that they probably will respond to immunosuppression better than patients who don't have a PNH clone. Yeah. Okay, thank you so much.
great presentation as well. I hope everybody enjoyed that. I keep forgetting. Lunch is just being put out. I think we're finishing up just a little bit early. So please stick around for lunch and chat with one another. And again, just remind you about the resources that we have. And thank you very much for coming, all of you, today.